Welcome, everyone. Happy Friday. Thank you for joining us today for AHRMM's The Healthcare Supply Chain's Response to COVID-19 webinar. We're moving into post-COVID-19 supply chain conversations, and today we have a wonderful panel to share with you. I'm Dee Donatelli. I'm the Vice President of Professional Services at Track Manager and have the privilege of serving as AHRMM's 2020 Board Chair. Today I'm joined by Mary Beth Briscoe, another AHRMM board member, and has a lady who has been a CFO for a long time in our industry. So we're going to have a lot of fun today asking our panelists some hard questions. But just a quick note for those who may be unfamiliar, AHRMM is a national professional association dedicated to providing education, leadership, and advocacy for healthcare supply chain professionals. Throughout the COVID-19 pandemic, AHRMM staff has worked tirelessly and very closely with government agencies, healthcare leaders and professional organizations, our country's GPOs, manufacturers, and distributors to provide the most up-to-date information and resources available for our members and the healthcare industry. If you've not taken advantage of it, please visit the AHRMM website. There is a plethora of wonderful information that help guide us through these difficult times. And just quickly, like we have to do on all of these, some housekeeping items for today. All your lines have been placed in listen-only mode to help our audio quality, but you can always ask questions, and we encourage you to do so in the Q&A box. The Q&A box can be opened by hovering your mouse over the button on the WebEx browser, the little ellipsis icon that has 3 dots. If you click on that, the Q&A box will pop up. So we look forward to your questions, and we'll try to infuse those into this panel discussion as best we can. So without further ado, and if I run out of time or forget at the end, I want to thank these 3 individuals for spending time with us today. First of all is Dr. Colleen Cusick. Colleen is the Director of Materials Management at the Johns Hopkins Hospital. Secondly is Dr. Gloria Graham. Both of these ladies are DMPs and have been very active in the industry. I've known them for a long time through AVAP as well as AHRMM. Gloria serves as a clinical value analysis analyst at Cincinnati Children's Hospital Medical Center and brings a wonderful knowledge of information around pediatric care. And finally, rounding out our group today is Matt Putman, who is the Director of Supply Chain Operations at the University of Colorado Health. Welcome, everyone. As a preamble, I want to start off by saying that as I've kept in touch with many colleagues across the industry, I think we're all being asked very difficult questions by our bosses. The most recent of which was probably emphasized earlier this week on a WebEx that I was listening to, where the executive supply chain individual at a hospital said, if I haven't talked to my CEO 10 times a day, it's been 20 times a day. So we thought today it would be fun to have Mary Beth put on her CFO hat, many of us reporting to CFOs, and ask some difficult questions. Let's see how our panelists answer. Mary Beth, over to you.
Thank you. Thanks, Dee. And again, I'd like to thank the panel and the AHRMM staff for everything. And just based upon our call earlier this week, this is going to be very informative and a lot of fun. So again, thanks to the panelists. Okay, let's start with question 1, and this is for everyone on the panel, okay? So the first question is, what should our organizations focus on when we're considering how important our distributor and manufacturer relationships are, particularly as it relates to things like surge inventory levels, contract language, capacity issues, things like that. So I want to start it off with Matt and then Colleen and Gloria. So Matt, what do you think about that?
Well, good morning. Thank you. You know, there are a lot of things to consider right now because the way that we have delivered healthcare supply chain in the past is truly now in the past. This is the time that we have to re-engineer how we are going to deliver healthcare supply chain moving forward. And so I think we have to, as an industry, continue to look at how everything is delivered, whether it comes from a distributor manufacturer, whether it is those surge inventories, how are we contracting differently, because a lot of organizations got caught, and I would say the healthcare industry as a whole got caught behind the 8 ball at times because we didn't know how serious this was going to be. When are the surges coming? Are the surges coming? And things of that nature. And so really what we have to do is we have to consider what is going to help position healthcare supply chain, healthcare facilities, and really focusing on the impact to the patient, being able to supply our clinicians, our caregivers, and our communities with the products necessary and the services necessary to be able to support the care that's given and to be able to reactivate, because obviously whether you're in the midst of the surge, whether you're past the surge, or whether you're preparing for the next surge, we still have to keep the lights on. We still have to keep the business running. And so we still have to deliver high quality care, but we have to think differently because now reserve stocks become important, because as we're contracting, we have to know that the country of origin is listed out, or that services can still be provided in a pandemic situation where we have to reduce the vendors that are coming into our procedural areas and things of that nature.
All right, this is Colleen. Good morning. So I think it's important that we focus on truly what we need. There's a lot of things that we want, but we must let our distributors know what we do need. I think that we need to make sure that when we're getting maybe different substitutions and different brands, maybe we have to go to different distributors. We have to communicate not only with these distributors, but also we have to go back operationally to ask our clinicians, are these good substitutions, from a safety standpoint for patients and infection control, that we have quality, safe products. I also think that we have to understand and step back and look at the distributors and manufacturers' point of view, because we really are all in this together. We cannot do without them. We have to be able to take care of our patients. We have to understand that while we're anxious about getting the amount and the allocation that we need, they are doing the same for all the hospitals that are requesting their, what they're able to provide. I think the other thing that's interesting is in the past, we've actually met with our manufacturers and distributors to understand what their plans would be. I think this came to light during the mini bag shortage, well, what happens if there's another hurricane? And so I think we have to sort of think future strategies, what we will do if this happens again, what happens in the fall, how will contract specifics hold up during a time of limited resources? I think those are all questions that we need to have frank discussions with our manufacturers and distributors.
Okay. Gloria.
Hi, this is Gloria. So I think in addition to what Matt and Colleen have said, they've brought up some great points. And, I think Matt really, hit it, head on when he said that, supply chain is going to be different when we, go forward with this. And historically, we've really had to focus on things such as optimization to really reduce the costs and keep a low level of our inventory, but unfortunately that has left many healthcare organizations, really in a vulnerable state. And so how do we prepare the supply chain? How do we as a healthcare organization move forward to be able to still achieve some of those outcomes, but also be able to absorb and handle any disruptions that may come along against the supply chain? Because we all know, this is not, this will repeat itself, and we will begin to see, I think, more disruptions as we go forward. So really beginning to understand what can we do differently and how can we work with our distributor and the manufacturers going forward. I think more than ever before, this really has to play into the part of having that relationship with the suppliers and your distribution to really, like Colleen talked about, I think understanding their plans for how they handle disruptions, I think is vital, so that then we as healthcare organizations will know and we can build our policies and processes around that and really understanding that. I think the other thing that this experience has brought out is while standardization has been something we have all worked towards for the most part. Now, with my experience in pediatrics, standardization is not always something that we can achieve just because of the nature of taking care of the pediatric population. We struggle with finding one vendor who can provide the width and the breadth of the products that's needed for the whole range of patients. But I think we will look at standardization going forward in a different manner, that we have to understand that while that may not necessarily always achieve what we want it to be as far as to be able to have that flexibility so that you can absorb the disruption. So I think standardization will be a key thing going forward to look at, maybe not necessarily putting, I hate to use the cliche, all of your eggs in one basket.
Well, and you bring up a good point, and this is where having that strategic partnership with vendors is going to be paramount to the success of supply chain going forward, because you not only have to ensure that you have the right product at the right time for the clinician, so you have to have the clinician buy-in and the clinical guidance on that. So whether it's through value analysis teams or clinical stakeholders brought to the table, but you also need to bring together that with the vendor partners, because degradation plans are extremely important during this time. If we can't get product A, where are we going to get product B? And so I think we have to think about, where do we bring in our vendor partners so we understand what their degradation plans are, knowing that production may be up on this product, but that's going to run short, so now we're going to get to this product. And one other thing to add on to that is making sure that they're also part of the reactivation plans as you go back into procedures, whether they be surgical, GI, cath lab, things like that, because our organization has been able to put together a look ahead of the next 72 hours of procedures to say, this is what we're expecting to do, here's the case volumes, do we have enough staff, do we have enough equipment, do we have enough bed spaces, but also do we have enough products, whether it's the PPE of gowns and masks or whether it's the actual surgical products used. And so making sure that our vendors are aware of that as well, so we're purchasing our full allocations, we're not leaving anything on the table, and things like that. I mean, that's where we have to have that full collaborative view and re-engineer how we're going to deliver this care, because the patients are going to continue to come. Unfortunately, many times patients are almost waiting too long to come to the facilities, so they're even sicker than when they would normally come to the facility. So we have to make sure that we are on top of the game with the products that we deliver, with the services that we deliver, and being able to support that care that's so vital at this time.
So Mary, this is Dee. Can I ask another question?
Absolutely.
Thank you. I'm going to put my supplier hat on for a minute, and I'm going to push a little bit. So we've been talking partnership and the importance of relationship management and having secondary backups for as long as I've been in this industry, which for those of you who know me has been a long time. What's going to change? How am I, as a supplier, supposed to establish a relationship with you, Colleen, at Johns Hopkins when I don't have a GPO contract and I can't even get an appointment? Answer those questions for me, ladies and gentlemen.
Sure. So I'll start. So I think this is probably one of the biggest challenges, because obviously, you know, if you are our distributor or you're our manufacturer, and we do have that relationship and we have established that, but suddenly because of allocations, because you're not able to get items, you know, now I have to look at someone else who maybe I have not had an established relationship, and you know, taking that supplier side, the supplier says, well, what are you going to do for me if I do help you here. So I think this is going to be very individual. I don't think there's going to be any blanket answer, meaning all manufacturers are going to say, yep, we're going to sell it to everybody. And I think it's, it may be that partnerships will be different, meaning, well, okay, maybe a certain percentage we'll give you and a certain percentage we'll give you. Although that also can hurt you because you won't reap the financial, you won't have that financial positive when you have everything at 80% or 100%. So I think this is actually what I think, and I don't think we'll answer it today. I think it's something that needs to be on the table of what happens when there are these major events. We've had a couple of them. This certainly has been the biggest one, at least in my career. But we maybe can't afford if you're not our primary distributor. So I think we really need to, as a collaborative group, to answer this question.
And this is Gloria. If I can interject, I think Colleen, really explained it well, and I think she brought up a great point in that I think the conversations that we will have going forward with distribution and with our GPOs, we may need to come up with a different model of how we do business and how the GPOs, how we do write contracts in order to allow this flexibility and to be able to absorb some of this disruption. The way that we're doing the business model today, it's not working. And unfortunately, we hear stories of hospitals that have been without. And so we do need to put a different lens through this and figure out how do we do things differently with our GPO and with distribution in order to allow in times such as this to be able to work and engage with those suppliers that may be outside of the, traditional contract.
And I would add one more thing is that this is also going to change how internally within facilities the supply chain operations work, because you have a lot of low unit of measure and stockless systems. You have what's kind of going the way of the dinosaur is the bulk traditional inventories, although now if you look at it, that's now going to swing the other way on a pendulum. So how do you engage some of your distributors to possibly even a 3PL relationship or other ways to ensure that there's backstock, but you're also not blowing the finances by holding too much inventory? And so then you get into how are we going to be utilizing a Kanban, or are we going to use a PAR system? So there's so many variables there, but at the end of the day, being able to find that sweet spot of inventory management or contracting language, that's going to be really what's going to evolve here in the near future.
And I think the contracts might be written that, here's normal time, and then in the times of limited resources, this is what you could expect. Because I'm not sure that they're written that way right now. Because if you normally are getting, 100% allocation and suddenly now you're at 70% because of the limited resources out there, are contracts really written like that? And the answer is probably no.
Okay. So, again, would like to remind everyone, if you do have a question, please go ahead and put it in the Q&A so that our panelists can answer them during the discussion, or we can wait until the end, but do want your questions. Dee, would you check and see if we've got any questions in the Q&A box, and do you have any more comments about our distributor-manufacturer relationships?
No, I appreciate the comments everyone made. I think they made sense. There's one question here from our friend Howard Mann. Hi, Howard. Hope you're doing well. And this would probably be mostly for Colleen. Have you had any collaboration in the New England and Mid-Atlantic States collaborative that's been talked about in the news? Are you aware of that or participating at all?
I am not aware of that, although we have a collaborative here in Maryland, mostly related to the opening of the field hospital. I am familiar about that, where University of Maryland, Johns Hopkins, and the state of Maryland have collaborated both from a clinical and a supply chain standpoint to open up the facility and is currently taking care of patients.
Perfect, thank you. Our other Q&As are coming in, and basically everyone's agreeing with, the lean philosophy, the single source vendors, all things you've touched on. And there's a couple other questions here, Mary Beth, that we've already planned to get to, so let's go on with the next question.
Got it, thank you. So we just got through talking about how important relationships are. Well, let's pivot to technology, because we all know how important technology is to support what we do every day just in a normal course of business. So question for Gloria and Matt. How can systems engage with advanced analytics to help guide decisions? And particularly really interested in discussing the use of technology now to plan for needed resources. And then just to make it a little bit more difficult on you, what technology is lacking? What technology do you wish you would have had internally and externally? And then we'll talk about how to scale such technology. So a lot about technology. How have you used advanced analytics? Are you planning and using that technology for needed resources? And then kind of wrap up by saying what you wish you would have had that you don't have in terms of internal and external technology. So Gloria, that one's for you first.
All right, thank you. Yeah, I think, going forward, and we have in the past as well, using the analytics to really help us in guiding our decisions. I think it's been vital and just so important, obviously, for us to have that visibility into our inventory levels. As Matt was talking about, the changes that we're going to be seeing as far as some inventories are a little bit leaner, that low unit of measure versus having more of that bulk, and really understanding exactly what you have, being able to visualize the exact products that you have, knowing and understanding then the usage rates that are around that, I think is crucial. So for example, some of the things that we've done, to help us be able to know when we really need to engage with the clinicians in order to look at either a change in practice or maybe a change in the product. We've been able to take just some internal processes and being able to really look at all of the departments. What we did is we took our top 20 departments and really began to track the usage of the items, the PPE items that everybody has been chasing for the past, several weeks. And what we've been able to do is kind of look at that against what we're using per day so that we know exactly what day, if we weren't to get any other shipment, any other product on board, we know exactly what the last day of supply would be so that we can then engage the clinicians ahead of time so that we can begin to talk about alternative practice. And Matt talked about earlier about the degradation plans. That's one thing that we are really highlighting in this, I think, has really kind of brought to life. And one of the things that we're using analytics for is to help us just knowing what products are on allocation. So we have a total, just for us, about 200 products that are on allocation. So the plan within value analysis is we're going to work with the clinicians to then begin to figure out the most crucial ones and making sure that we have those contingency plans, whether that's contingency around different products, but also around practice, because that's the engagement of the clinicians that you need. So I think having those advanced analytics to help you then partner and work with the clinicians and really become part of the team that's really looking at how do we take care of the patients that we serve. As we've talked about that it's not just in this disruption, but how are we taking care of the patients outside of this pandemic that we're seeing that are coming in to our hospitals, and making sure that we have the appropriate supplies for our clinicians to manage those patients outside. And so, you know, I think there's lots of technologies that are out there that, you know, individuals can use to help them gain access, and making sure, I think the most important thing is making sure that you're having the accurate data so that you can really predict and use those predictive analytics to help you in manage this and working with the clinicians.
Okay, Matt?
Well, I'd like to start out by answering the second part of the question first, if I could, about what technology we'd like to see. I'm really hoping that either Apple or Microsoft has that crystal ball app ready to go, so we know what to be expecting going forward. But no, in all seriousness, when it comes to the advanced analytics, Gloria nailed it, where we had to watch what our daily burn rate is, because if you're in a bulk warehouse, you can always walk to the shelf and say, well, I've got that much, but what does that really mean? And so what our organization did very early on is that when the first rumblings were really starting to happen within our state, there was a movement to start masking everyone. And what's the right mask to use? Is it an N95? Is it a procedural mask? What is it to get out there? And so then we quickly determined what our allocations were first, what our burn rates were if we had to mask everyone or just people that were in COVID units and things like that, to then be able to say, where do we go from PAR management to conservation, meaning that we're going to start tightening down the PARs or even remove and say that there's a checkout point, to rationing, meaning that you will come down and you will get your one mask today. If you burn through that mask, then you do not get another one for the rest of the day. And so being able to have the analytics that say, what are our triggers? It kind of goes alongside with that degradation plan, but you have to know, when do I raise the red flag to say we need to make a movement as a team? The other thing that our organization did during the heat of the battle, if you will, was that we got a lot of collaborative groups together. Nursing leadership, infection prevention, even our vendors and distributors on the phone multiple times a week saying, what are the allocations looking like? What's our stock status across the system, knowing that our system is one that varies between low unit of measure and just-in-time, low unit of measure just-in-time inventory and a bulk traditional warehouse inventory, or what we've started creating in a number of facilities, which is hybrids, where when we have items that require a little bit more acute awareness to it, we can put it into a perpetual. We can issue out the stock. While it's not the most conducive to most low unit measure type of facilities, it still allows us the ability to track what our daily burn rates are, see where our allocations are, see where we can transfer product around internally before we really have to hammer on the vendors to try to produce something that everybody else in the country and in the world is trying to produce as well. And so being able to have those advanced analytics to put into place those triggers, and then as you move out of the COVID times and into the reactivation times, what is our burn rate as we start adding more patient population into it? Now that we're talking about surgical gowns and surgical caps and surgical gloves, what's our burn rate on those that typically have been going down, and we haven't probably even been purchasing all of our allocations, but now that we're starting to see that uptick, what's the maximum number of procedures that we can do in 30 days or 45 days based off of our PPE and burn rates to be able to really show that we can continue to reactivate and bring the patient population back in and build the trust of the communities around us. And so those are the really key activation advanced analytics that we look for, whether we're using our ERP system. And obviously, it all can be very scalable to large facilities and large systems to small facilities where you have to just be able to figure out what are the burn rates, what are the degradation plans, what's our triggers, and then also be able to say, as we're reactivating, where else can we go to try to move things back in the other direction.
And this is Colleen. I just wanted to add about what's lacking. I think I think what will emerge, and it will be a positive thing, is that better, more sophisticated models will become commercially available, like you said, from Apple or Microsoft versus homegrown models. But I think the smaller hospitals that don't have what maybe all three of us have, we have lots of analysts and people who can work on these various things that both Gloria and Matt talked about. But cost will be a factor for these commercially, once they're available models. But definitely that will be something that will come out of this.
So, Dee, do you have any comments about that? And can you check and see if our participants have some questions that our panelists can answer?
Well, if it's okay, Mary Beth, I'm going to give a little bit of a tilt because there's a lot of questions coming in for our panelists around, integration. And they stem from questions regarding virtual integration with larger health systems in your area, particularly, Colleen, to your point, if you're a smaller organization, versus do you foresee in the future that we're going to be kind of and I'm paraphrasing here, one man stand for himself, going into self-distribution models or even self-manufacturing to prepare for these kinds of things. And then more importantly, the integration with and visibility into upstream distribution channels. So I think there's a common theme in the Q&A going on right now around how are we integrating, how are we working together? And I know, Mary Beth, that feeds into your next question as well, so maybe we could touch upon some of those points.
Okay. So, all right, so let's just go there. We started the call talking about relationships. We then morphed into technology and data, and now we're going to go back to networking and relationships. So would like for the panel to talk about, have you seen a growth in networking with colleagues at your hospital, at non-acute care facilities, and community programs? I think also it would be interesting for you to also comment, do you think that that you were viewed differently now than before the pandemic? And do you sense that there are continued opportunities with local, let's say the non-medical manufacturers for some medical supplies? Do you see that as an ongoing opportunity? So, Colleen, let's start with you.
Okay. So I think while, there's been a lot of negative things happening, obviously, as it relates to this whole event, but I really do see that there's an opportunity to invite our non-hospital or non-health system-based healthcare colleagues, to network nationally and locally. I think the framework, as I stated, has started in Maryland with our field hospital business. I think it's an opportunity for AHRMM to look at, to be poised to sort of really look at these other groups that may have not felt included. I know from our standpoint, we are going out into the community at Johns Hopkins, going out into the community with GO teams to do testing in our nursing home facilities as well. So I think we will be obviously being able to know more people in the community, so I think that'll be successful. And I also think that the larger academic facilities, much like Johns Hopkins, that we are looked upon for guidance, both, locally and nationally, where what are you doing here? What mask are you using? Why are you doing this way? Or other kinds of activities. So I think that we should all be putting ourselves out there to help our communities. And I think the last thing that I think is really important is supply chain has really taken the forefront in a lot of places. Obviously, there's a lot of clinical care that's going on for our patients, but I think this is one of the times where supply chain has been shining because people do need us, and it has really put supply chain on the radar of senior leadership that maybe was not there, and maybe senior leadership looked at the larger capital purchases like an MRI machine, but in actuality today, it's not the big ticket item that people are worried about. They are looking at simple masks and gowns, and I think that we will see a difference in what emphasis on the disposables. And all three of us, we work with the disposables all day long, and but I think we've never had this much focus, and I think this is what's going to be one of the things that changes things. Because you know, if we can't have the gowns and the masks, we cannot do surgery, and that brings in revenue and reopens the hospital. So I think that's an important point.
Right. Yeah, and this is Gloria. Yeah, I think just to tag right in on to what Colleen was saying, you know, I agree 100%. I think this is really allowed the supply chain across the country and value analysis to really come to the forefront and really be able to demonstrate, you know, our connection to the patient outcomes and our ability to help the clinicians, you know, take care of the patients and achieve the outcomes, you know, that we're all striving to do. And I think it's been very interesting. I think just, you know, even just within my facility, the connection that I've had with the clinicians over the past several weeks in working with them around some of the contingency plans and products and things. And, you know, I've had so many of them comment that say, wow, I had no idea that this is, you know, that you had to do all of this and that all of this, how, and you know, they've also said, how do you do this? And I just can't, you know, can't believe that you're having to face and deal with all of that, and we just don't understand it. But I think now more clinicians are getting to understand and be aware of what we as supply chain staff bring to the table and how we augment and take care of, you know, the clinicians to be able to do what they need. And I think as far as networking opportunities, you know, this is, I think this really hopefully will shed some light on, you know, I know there's a lot of competition out there, but I think this really demonstrates, you know, the need to really be able to, as Colleen was talking about, being able to help share best practices, to be able to share the knowledge and the experience and things that we've all learned from this. I think it's going to be very exciting to see a lot of the literature that comes out of this so that we can all learn and become better prepared when further disruptions are going to happen. And some of the examples that we've done, you talked about, Colleen talked about the collaborative in Maryland. We in Cincinnati, we have a Cincinnati Health Council. That's a collaborative of the local hospitals. And we've been very engaged with that from, you know, pandemic planning, from the supply planning, but also from best practice. And we've been able to work with some of the local hospitals and do some exchanges. You know, we were able to exchange supplies with a hospital that needed a certain type of supply that we felt comfortable enough that we had enough on hand, and then they in turn were able to exchange supplies with us. So I think you will continue to maybe see that even more so in the future. And I think there are lots of opportunities going forward with non-medical. And I think it's been amazing to see that the manufacturers that have really stepped out that are not a traditional medical supplier, they've been able to step up and switch those gears to be able to provide, you know, what is needed for the healthcare community to be able to manage through, you know, through this enormous experience. So I think there still will be continued relationships to help, whether you're trying to just build up your pandemic stock, whether you're just using them for augmenting when maybe we aren't at 100% allocation. So I think it will be unique as we go forward to see how do we write that opportunity with non-medical manufacturers in certain contracts and processes and policies.
Well, and I would like to add, I mean, both Colleen and Gloria said that the importance of supply chain is really being shown now. And We use the old phrase to go from the basement to the boardroom. Well, we are definitely in the boardroom right now, because whether it's incident command centers that are spun up to be able to ensure that we have what we need, and also the patient flows and anything like that. But really, when we get down to the crux of this, it's a matter of determining how do we support the communities that we serve. Our organization has a number of affiliates that are not necessarily owned or guided by our system, but they're kind of a partner facility. And so when we started having, again, the early rumblings, a lot of the COVID action, we were in communication with those facilities that are typically smaller, more rural type of facilities to say, these are some things you might want to do. And so that intellectual partnership really, really is beneficial, because you have facilities that may not even think, well, this isn't going to even hit us. Well, all of a sudden, one of our affiliate partners is saying, hey, what are you doing with this? Oh, well, here's what we did. Oh, that made all the difference in the world. Or to the point of being able to share product around. Just being able to support the communities, because again, we are in healthcare to help support the patients and the communities. And so if we continue to have that focus first, the networks, the affiliations, the partnerships, just the intellectual sharing is all very, very important, and we need to do that to the best of our abilities.
So, Dee, any thoughts around that, the comments, and any questions? We've got about 20 minutes. I want to be sure we get to everybody's questions if we can.
Actually, it's interesting, Mary Beth, on some previous webcasts that we've had very few questions. Today we are being bombarded with them, which is wonderful.
Yay!
And I would just let our audience know that our hope and goal here at AHRMM is that we are going to continue these on an ongoing basis, specifically moving into this conversation of kind of recovery or what's next. So if we don't get to your questions today, we are recording them, and we will make sure that at some future date we hit on these, because they are some awesome questions. One that I particularly find interesting for our panelists to discuss is from Trent West. One key to dealing with the challenges is to standardize and to rationalize the supply base. Matt, you touched upon that. Can you elaborate on what you're specifically doing and the success that you've seen from right-sizing your supply base? Matt, you want to take that one?
Sure. So how do you act nimbly to right-size that supply base? Who are the right partners? Who are the strategic folks to bring into the conversation and say, well, what products do we have? How quickly can we procure? Because obviously when all of this started, we were inundated with very generous offerings of people to donate, or, hey, I know a friend of a friend of a friend who can procure something out of China, but it's going to be 8 to 12 weeks out. Well, we didn't know what the world looked like, and so we had to look internally to who are our partners, not only in the acute space of the hospitals, but also in the non-acute spaces. And so to be able to look at both and say, how can we partner together and re-engineer how we do things? Because just because you may be a non-acute space provider, can you help support our acute spaces? Are there allocations that aren't being purchased there that we can move into the other venue and things like that? And so to be able to right-size quickly, you have to get a very quick and good idea of the landscape. Now, we don't know what's going to happen tomorrow, but we do know what today looks like, and we can have at least an inkling of what tomorrow is going to look like. And so by working collaboratively with your nursing leadership, infection prevention leadership, getting some baseline advanced analytics down there to say, well, what's my daily burn rate? Talking to the vendors, what are our allocations, and then just really trying to work to build that foundation of what do we have, where are we going to go, and what are our plans if I don't get this anymore? Where do we have the opportunities to still support the care that we're given? And so it requires a different mindset to act very nimbly about how we're going to get to where we're going to get to. And that's really where our organization had to think about this really in an incident command type of structure, where we said, if a tragedy happened, how would we react? And we have to take this in the exact same mindset, knowing that we're past the sprint. We're on to the marathon. This is going to be here a while, but we still have to act like this is something that is going to happen very quickly, and we have to be nimble to be able to adjust. So whether it's stock levels, whether it's vendor partnership, whether it's I hit my trigger that I now need to start being concerned on the quantities that I order, it's all those types of mentalities that you have to put together very quickly and understand where do I have a right sizing of my inventory to support the care going forward.
And this is Gloria.
Oh, go ahead, Gloria.
I was just going to say, just a simple example of one of the things that we did, and I don't know if the person that asked the question was wanting, something, maybe an example, but just one thing that I thought of early on, when we began to kind of put that incident command together, as Matt explained, one of the simple things that we did was just begin to pull some of the inventory of those PPE items out of the unit, like we have in the units, which a lot of people do, have those little cubby holes where you can put different supplies. And so we had to kind of pull that access and that accessibility that we talked about of those supplies kind of more to a central station, so that, because the fear in staff and even patients and families begin to obviously creep up and wonder about, am I going to have the right supply that I need? So just a very simple thing that we did was pull those supplies and bring it into more of a central location on the unit, so that, as Matt talked about, having those analytics so we could really know exactly what was on each unit and how much they were using, so that we could really have that information and data to help us when the organization as a whole was trying to plan for what we have on hand and what do we need to do next.
Yep, that visibility. So let's build on this a little bit. Colleen, I'm going to direct this towards you. Several questions have come in about, as we've had to expand our sourcing capabilities, dealing with overseas customs and shipping and air travel that we don't normally have to take into consideration, how have you skilled up for that? And then a secondary part of that question is, I know as we talk about the globalization of supply chain management more effectively, do you see a willingness, and let's just use your organization as an example, to begin paying slightly higher, 5 or 10% increases for United States made products?
So the first part is we did have to skill up on dealing with overseas purchases. I think some of it was finding the right people who could be content experts. All of us cannot be, I think we have to make sure that we are humble enough to know what we know and what we don't know. And so we did get content experts to work on that in our sourcing and purchasing department. So that was number one. Number two, I think the reality is that we will pay more. I think we have paid more currently just because they're if I looked at all the people who have emailed me in the last 60 days of the masks and things that they have, you would sit here and think, oh my gosh, there's no problem at all. There's masks everywhere. But I think that we have to be careful that these are vetted companies, that they really do have the products that they say, that they really do, that they are not just trying to commit some kind of fraud. And so it is part of what sourcing and purchasing needs to do is to take the time to make sure that we are vetting these sources. The second part, obviously, is we have to be careful of our cost controls. What can we afford? Is it the same quality and safety for our staff? But I do think we will pay more because if manufacturing comes here, it is more costly. But I also think we have to. I think we can't be short-sighted. Are there other countries that could also be part of partnerships? I mean, right now, of course, the Asian countries are not the only countries that we purchase from, and so, are we able to purchase from other countries that are able to scale up as well, and maybe again, as Matt had said, or Gloria, not putting all of our eggs in one basket, but it would be nice if there were other countries that would be manufacturing.
Other thoughts from the panelists on this topic? If not, here's one, Matt, to build on one of your comments earlier. Are you at the University of Colorado going to be moving towards more a low unit of measure? Are you thinking about bulking up, or how are you considering FAHRMM in the future?
Sure. So from our operational system, we started at the PAR level, the point of touch with the clinician. We are a Kanban implemented type of methodology. And so that has proved to be very useful in allowing us to figure out days on hand of stock, burn rates, things like that, which then allows us flexibility moving back towards how inventory is procured. We are an organization that has both a LUM environment and a bulk environment. And then also in some of our smaller facilities, because they are a little bit more rural, we do a hybrid of a LUM and bulk just because real estate is very valuable, and so we're not given large expanses to build warehouses. And so we have the ability to put certain things into a perpetual environment, more like a traditional, but also still do the predominance of our purchasing through a LUM environment. And what that allows us to do is to toggle between whether we want it to be in a bulk account or a LUM account, and if something is going to start going on to a back order or a pandemic level, then we can toggle between those to really be able to support. But I think when I said that we're going to see a re-engineering of how supply chain works, my focus is really on the operational aspect, and I can actually see a movement away from a true LUM or true bulk to actually be more of a hybrid world, because it gives flexibility. It allows you to control your costs by reducing down some of your overhead, even though utilization is still going to be utilization. But it allows you that flexibility to be nimble and make decisions. Even back when we were in 2017 with the IV solution shortages, we were able to put some items in bulk, some items stayed in LUM. We were able to share throughout our organization, large facilities, small facilities, and we were able to stem the tide of that concern time without any patient problems, without any visit problems. And so just that flexibility of having both LUM environments and bulk environments is actually very beneficial. And so we talk about standardization moves across organizations and products. There are times that standardizations in distribution methods can be a benefit. There's also times that it can be a negative. And so I actually see that things are going to kind of move more towards that middle ground as that pendulum swings, where you'll have organizations that will try to come up with a little bit of both, where maybe larger facilities that have more real estate can be a bulk environment that can help support some of the smaller facilities, or even vice versa. If you have multiple smaller facilities, they can have more of a bulk environment and be able to store a little bit of extra pandemic stock here and there to be able to support going forward.
Perfect. That was a great answer. Thanks, Matt. So with the remaining 6 minutes, I'm going to give each of you 2 minutes apiece. What's the major thing that you've learned, and how are you going to pivot or change as a result? So how about Gloria? You go first on that one. 2 minutes.
Oh, I get to go first. Okay. So yeah, I think one of the main things that I have learned is, in addition to everything that we've talked about today, just around the data, really understanding, your own processes within, I think this has brought to life even more so. I felt like before we were really integrated in with our clinicians and the processes. But I think this really has proven and shown that we need to be even more integrated to be able to really help and make a difference when we're trying to manage everything. And so I think for me going forward, having that degradation plan that we talked about, we've been talking about it for a while, and it just seems like, things would kind of get pushed aside. But I think for me going forward, that's one of the biggest things that I really want to focus on, so that not only do we have the plan around product A versus product B, but what is that potential practice change that may happen, and then how did that new practice change affect the products that either we do or we can't get. So for me, that was, I think, an aha moment that I really need to focus in on this going forward, and really have some more solid plans in place around, certain items that we really need to focus on, not only just for this pandemic, but, some of the other critical items that we use, throughout the organization.
Awesome. Thank you, Gloria. Colleen, how about you?
Thank you. Yep, I think there's going to be more emphasis on supply chain moving forward. We're going to be more out there, if you will, not sort of in that behind-the-scenes sort of support. I mean, we are a support service, but really out there. I think that people realize that we are more patient-centered than maybe they realized. I always emphasize that with my staff. I think what also has been brought to light, and a subject near and dear to my heart, is that I do believe our clinicians do need some kind of basic education in supply chain to understand where their products come from. They're not always downstairs. We've done early on, we did some rationing of supplies, to make sure that everyone got supplies. And I think, again, our clinicians need to understand, understand some basics. I think that there has been more collaboration with supply chain. I think in our value analysis process, we've always had collaboration, but sort of this is brought to light even more so. And I think, I think we also are going to see a lot more of cost control. We've got to see, where we're spending our dollars. Are we spending them in the right place? Are we getting, the right products and in the right amounts, and making sure that we are using the products that we are buying? And so I think all of these are pivotal topics that we all need to look at.
Great. And Matt, you want to bring us home?
Sure. I would echo everything that Gloria and Colleen said. I mean, when you look at supply chain, people typically think about just the operational side of how do you get widget A into the clinician's hands. But to have that fully rounded group of value analysis, having nurses reporting into supply chain, helping with clinical decisions, having procurement, obviously, AP, which is all part of the finance aspect that we all report up to. When you look at your purchase services team and your capital team, what are the right vendor relationships that we want to have to be able to support the care that we're given? And then finally, the informatics side, or the ability to have the advanced analytics, so we can track and report and record what it is that we're spending our money on to be able to support the care that we give. I see nothing but supply chain becoming that much more important, getting that much more of a foothold and a seat at the boardroom table, that I see a really great future for us going forward. Whether it's in a pandemic situation, whether it's business as normal, or whether what the future is going to hold, the world needs a good, strong supply chain. And Elon Musk said that at one time that this supply chain stuff is hard. Well, not everyone goes into supply chain, and they'll never have a TV show about supply chain 911. But at the end of the day, we do this for the patient care, we do it for the right reasons, and we're here to support the patient care going forward.
Well said, Matt, well said. Unsung heroes for sure. And I want to assure everybody that the questions that we didn't get to today are going to serve as excellent outlines for future webinars, so I hope that you will join us in the future. To our panelists, we can't thank you enough. Mary Beth, great. Thank you for playing CFO for us today. I hope everyone has a great weekend. Everyone stay well. Thanks for joining.